thrombosis, we will discuss the basics of disorders of hemostasis and thrombosis. In this last section of our lecture for this semester, this will be our last lecture for this semester. So the basics in disorders of hemostasis is what we are going to be discussing. Then we'll take a look at the laboratory investigations, few of the basic lab investigations also in hemostasis and thrombosis. So under disorders of hemostasis, I'll outline disorders of primary hemostasis, disorders of secondary hemostasis, and other disorders of hemostasis. That's how we are going to take it. All right. So our objectives are, at the end of this class, you should be able to classify and describe the clinical manifestations of disorders of hemostasis, describe the pathophysiology of coagulopathies, both bleeding and thrombotic disorder, enumerate and describe the laboratory tests for evaluating hemostasis, and contrast typical presentation of patients with platelet disorder versus coagulation disorders. Okay, we'll briefly take a look, take our back mind to primary hemostasis, the steps that are involved in primary hemostasis. We'll just refresh our mind before we now go into the primary hemostatic disorders. Okay, first of all, we talked about transient constriction. We talked about platelet adhesion. We talked about platelet aggregation, and a release of platelet granules, and then platelet aggregation. You find out that at each of point of these steps in primary hemostasis, any abnormalities that affect platelet adhesion will result in an abnormality of the primary hemostatic mechanism, or any process that will interfere with platelet ADP release and thromboxane release will also affect the primary hemostasis. So that is what this picture here is trying to depict. When you look at this diagram, you see a deficiency. Glasman thrombasthenia is trying to show us that there is a defect in this receptor glycoprotein 2B3A complex, and any defect in this receptor results in this disorder named Glasman thrombasthenia. Any abnormality with glycoprotein 1B receptor, the receptor involved in platelet adhesion, will result in a deficiency or in a disorder referred to as Bernard-Soulier syndrome and all that. So we'll look at it one by one. So it's not something that you'll be able to disorders of hemostasis are specific, okay, to the pathway, through the pathway that are involved in the hemostatic pathways, either in primary pathway or in the secondary hemostatic pathway. So any disorder you find that is being described in hemostasis or bleeding disorder, you find out that it goes down to one or two of the pathways that are involved, either in the primary hemostasis, or in the secondary hemostasis. Any disorder should be pinned down to the pathway that is being affected or the receptor that is being affected, and if it's as the molecular level or the phenotypical level that the abnormality occurs. So primary disorders of primary hemostasis are usually due to abnormalities of platelets. Okay, you can also recall the primary role of platelets in primary hemostasis. Platelet is the primary cell that is involved in primary hemostasis. So any abnormality that affects platelets play a major role in primary hemostasis. So anything that can affect the platelet will definitely also have an effect in the process of primary hemostasis. So we say that primary disorders of primary hemostasis are usually due to abnormalities of platelets. It's divided into quantitative and qualitative disorder. So quantitative disorders of primary hemostasis, their clinical features, that is quantitative disorders of primary hemostasis, hemostasis that are due to reduced quantity or abnormal increase in quantity of platelets. So their clinical features of the quantitative disorders of primary hemostasis include mucosal and skin bleeding. Symptoms of mucosal bleeding include epistaxis, bleeding from the nose, hemoptysis, GI bleeding, hematuria, menorrhagia, intracranial bleeding, which occurs with severe thrombocytopenia, that is severe reduction in the number of platelets. Symptoms of skin bleeding include easy bruising, bruising with mild trauma, bruising without trauma, trachea without trauma, no obvious injury, no obvious trauma, but you find bruises in the skin. You can see this diagram here representing the various degree of the spread of the bruise on the skin. We have the one we call trachea, the smallest one, A here, represented as a pinpoint bruises on the skin. When you observe some people, you must have come across some of the discoloring of the skin or stuffs like that. Then we have ecchymosis, B, represented by B, symbol B, and it's greater than 1 cm discoloration of the skin, or hemorrhage. Purpura is larger than all of them. So these are symptoms of primary quantitative disorders of hemostasis that occurs without trauma. So these are the clinical presentation of quantitative disorder of primary hemostasis. Now, some of the useful laboratory investigations that we can do to investigate primary hemostasis, you go back and ask yourself, what is causing the primary hemostasis? We talked about platelets. So what are some of the things we can do in the lab to investigate this primary hemostatic dysfunction? You have to recall that, number one, you have to know what is the quantity of the platelet, what is the bleeding time, to investigate the integrity of the blood vessels, the blood smear to look at the platelet morphology, whether morphology of the platelets are normal, then bone marrow biopsy. Then going specifically to some of the quantitative primary disorder of hemostasis, we have what we call ITP, immune thrombocytopenia, as a case. Okay, this is an autoimmune production of IgG against platelet antigen. Production of IgG against platelet antigens, glycoprotein 2b and 3a. It can be acute or chronic. Okay, it is the most common cause of thrombocytopenia in children and adults. So you find out that in this immune thrombocytopenia, that autoimmunoglobulin are being produced against this platelet, very important platelet receptor, glycoprotein 2b3a, that is involved in platelet aggregation. And when that happens, you find out that platelet aggregation will not go on as it should. So the pathophysiology of ITP, we have that there are autoantibodies are produced by plasma cells in the spleen of the individuals. These antibody bound platelets are consumed. These autoantibodies are produced by plasma cells in the spleen against these platelet receptors. So they now bind with the platelets. Now the antibody bound platelets are consumed by splenic macrophages, resulting in thrombocytopenia. So the spleen, the plasma cells in the spleen are producing these autoantibodies, which binds to platelet receptors. So the platelets-bound antibodies are also being consumed out of the circulation by macrophages located also in the spleen. Okay, so that should be ringing some bells in your head. Okay, it can arise, the acute form of ITP can arise from children weeks after a viral infection or immunization. It is self-limited, can usually resolve within weeks of presentation. The chronic form of ITP arises in adults, usually women of childbearing age. It may be primary or secondary due to SLE, may cause short-lived thrombocytopenia in offspring. Okay. Laboratory findings. What can we see in the laboratory if this condition is present? Decreased platelet count, of course. You should anticipate that because platelets are being consumed by the splenic macrophages. As they bind to the autoantibodies, they are now consumed, removed out of circulation because they are seen as abnormal cells in the body. So they are being removed from the circulation. So you expect that their volume should be low. Okay. Normal, you expect that PT and APTT will be normal because where the pathophysiology is taking place is still at the level of platelet aggregation, primary hemostasis. And you know that the PT and APTT measures the secondary hemostatic pathway, the extrinsic pathway and the intrinsic hemostatic pathway. Okay, so those pathways, the secondary hemostatic pathways, are not yet affected. So you expect the PT and APTT to be normal. Okay, so I'll take time to explain it there so that subsequently when you read any disorder, you should be able to know exactly what is happening and know what the laboratory finding should be. So you don't expect PT and APTT to be affected because what is happening is that platelets are being affected. Okay, so the secondary hemostatic mechanism somehow still intact. Increased megakaryocyte on bone marrow biopsy because of the platelet that is being consumed. You expect that the body feedback mechanism will trigger the bone marrow to produce more platelets since the one in circulation is below normal. So treatment, the suggested treatments include initial treatments, maybe corticosteroids, will prevent bleeding by decreasing the production of antibodies against platelets. Children may respond well. Adults may show early response but often relapse. They can also be given IVIGG, can raise platelet count in symptomatic bleeding, but the effect is short-lived. Okay, they can give immunoglobulin. Okay, so instead of the autoantibodies now attacking platelets, they will tend to bind with this immunoglobulin and leave the platelets to participate in its function for a while. Okay, so the splenic macrophages starts eating the immunoglobulin instead of the IgG platelets. Okay, splenectomy, this is the last option. Eliminate the primary source of antibody production and the site of destruction. So it is the splenic plasma cells that are producing these autoantibodies that are binding to platelet receptor glycoprotein 2B3A, preventing it from participating in the primary hemostatic mechanism. Okay, it is also the splenic macrophages that are involved in eliminating, mopping up this antibody-bound platelets. So the spleen is the source of the antibody production and also the destruction of the platelets. So sometimes they may go to the extreme of removing the spleen. This is performed in refractory cases, in cases where treatments have often been off and on, off and on. Okay. So we have another disorder of primary hemostasis, disorder of quantitative disorder of primary hemostasis called microangiopathic hemolytic anemia. The it is the pathologic formation of platelet microthrombi in small vessels. So like capillaries, find that somewhere like capillaries, very tiny vessels to the very important organs. Find that platelets thrombi are formed inside these vessels. The platelets are consumed in the formation of microthrombi. As these microthrombi are being formed, of course, platelets plays a role, make up the formation of the thrombus and are being consumed in the process. Red blood cells are sheared, okay, that is, they are being destroyed, they are being ruptured as they cross microthrombi, resulting in hemolytic anemia with schistocytes, that is, helminths. So as red cell try to cross the microthrombi, because the microthrombi sort of narrows the lumen of the blood vessel further. So for the red cell to move, to cross, to supply oxygen and remove carbon dioxide from the organs, as it tries to pass through those microthrombi that are being formed by platelet, it is being destroyed, okay, leading to hemolytic anemia. Disorders that can result in microangiopathic hemolytic anemia include TTPS and HUS, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome. Okay. So TTP will briefly define that. TTP is due to decreased ADAMTS13. Okay, ADAMTS13 normally cleaves von Willebrand factor multimers into smaller monomers for eventual degradation. Large uncleaved multimers lead to abnormal platelet adhesion, resulting in microthrombi. So von Willebrand factors that are being released, von Willebrand factor, we say they are multimeric glycoprotein. Okay, but before they are being released into the circulation, there is an enzyme we call the ADAMTS13. It will cut it into manageable sizes, because the larger the von Willebrand factor, the more platelets it can adhere to. Okay, it can bind to. So this ADAMTS13 helps in cutting it into small pieces so that it does not bind large number of platelets at the same time. So when this ADAMTS13 is deficient, you can imagine the von Willebrand factor are being released in large multimers, and they will bind a lot of platelets, causing this obstruction, microthrombi in the blood vessels. So that's what we mean by large uncleaved multimers leads to abnormal platelet adhesion, resulting in microthrombi. The HUS, hemolytic uremic syndrome, is due to endothelial damage by drugs and infection, usually in the brain or kidney. It's classically seen in children with E. coli, dysentery, result from exposure to undercooked beef. E. coli verotoxin damages endothelial cells, resulting in platelet microthrombi. Of course, we've said that earlier. Once the endothelial cells are damaged, the subendothelium are being exposed, okay, and platelet adhesion and aggregation will occur. So clinical findings in ITP include fever, renal insufficiency, CNS abnormalities, renal insufficiency for HUS, CNS abnormality for TTP. Or laboratory findings include thrombocytopenia with increased bleeding time, normal PT and APTT, anemia with schistocytes, increased megakaryocyte on bone marrow biopsy. Treatment is plasmapheresis, corticosteroid, remove and reduce to antibody. So we have also the qualitative disorders of hemostasis. So we've mentioned a few quantitative disorder of primary hemostasis. You should be able to differentiate all this, okay? So we have also qualitative disorders of primary hemostasis. Here we have Bernard-Soulier syndrome. We've showed it in the diagram earlier. It is as a result of genetic deficiency. Genetic deficiency. Qualitative has to do with the function. Genetic deficiency of glycoprotein 1b. And if you recall, this glycoreceptor is involved in platelet adhesion. So because there is a genetic deficiency in glycoprotein 1b, we have platelet adhesion is impaired. Blood smear shows mild thrombocytopenia with large platelets. So these are genetic disorders. Then we have the second qualitative disorder of primary hemostasis we call Glanzmann thrombasthenia. It's also a genetic deficiency of glycoprotein 2b3a. Platelet aggregation is impaired. And if you recall again, glycoprotein 2b3a is the receptor that is involved in platelet aggregation. So any deficiency in this receptor will affect platelet aggregation. We have aspirin ingestion. Aspirin irreversible inactivates cyclooxygenase. Then lack of thromboxane A2 impairs platelet aggregation. So this process will affect thromboxane A2, and you know that thromboxane A2 also plays a role platelet aggregation. So you have also uremia. Buildup of waste products disrupt platelet function. Both adhesion and aggregation are impaired. So these are some of the qualitative disorders of primary hemostasis. Now we go over to disorders of secondary hemostasis. Secondary hemostasis, as we said, aims to stabilize the weak platelet plug, and this occurs via the coagulation cascade. Excuse me. We said that during the secondary hemostasis, the aim is to stabilize to convert the fibrinogen that was used as a linking molecule in the primary hemostasis, to convert it into fibrin. That is the aim of the secondary hemostasis. The disorders of secondary hemostasis are usually due to coagulation factor abnormalities, the factors that are involved in the secondary hemostatic pathways. So some of the clinical features we will see in disorders of secondary hemostasis include deep tissue bleeding into muscles. We'll see the picture as we go on, and rebleeding after surgical procedures. Some of the laboratory investigations, we use the very basic ones: prothrombin time and activated partial thromboplastin time. So some of the examples of the secondary hemostasis, secondary disorders of hemostasis we have is hemophilia A. So we're going to discuss just classical hemophilia A, the very basics of it. So it's a genetic deficiency of factor 8. It's an X-linked recessive, predominantly affects males. It can rise from a new mutation without a family history, that is de novo. Someone may not really have a history of a family history of bleeding, can just show up like that in nature. We call it de novo mutation. And some of the clinical presentations include deep tissue bleeding, joint and post-surgical bleeding. The clinical severity depends on the degree of deficiency of the factor 8. So when you look at this diagram now, can see these are some of children that have hemophilia A. You can see the bleeding into joints and muscles. You can see it, very severe ones. You see it, acute complications of hemophilia. This is muscle hematoma. Then this is joint bleeding. All right. So these are still some of the long-term complications of hemophilia. You can see the abnormalities and the bone destruction of bones, the joints, also the nerves can also be affected. You can see this hand here. So these are some of the long-term complication of hemophilia. Okay, so that's why the managing a hemophilia case, you don't really give gap with administering the factor 8 they need, because without that they can develop some of these complications. So inheritance of hemophilia. Hemophilia A and B are sex-linked recessive condition, meaning the gene that causes hemophilia is on the X chromosome. Males have one X and females have two X. Hence, hemophilia usually affects males. When a male has inherited a gene that causes hemophilia on his X chromosome, it does not produce the clotting factor he needs, because the Y chromosome does not produce information for the production of factor 8. So in an event where a male inherits an X chromosome that is affected, okay, if he inherits X chromosome that is affected, he comes down with the disorder hemophilia, because that is the only chromosome that have the genetic information to produce factor 8. So if he inherits an abnormal X chromosome, okay, so there is no way he can produce factor 8, because the other chromosome is Y, and the genetic information for producing factor 8 is not in Y chromosome, it's in X chromosome. So if he inherits an abnormal X chromosome, of course from the mother, because the X chromosome he has definitely is coming from the mother and not the father. So if he inherits an abnormal X chromosome from the mother, he will definitely come down with hemophilia, because he will not be able to produce factor 8. When a female inherits a gene that causes hemophilia on one of her X chromosomes, she has a second X chromosome and therefore one normal gene that produces clotting factor and compensate for the hemophilia gene. These females are said to be carriers of hemophilia. So in the case of a female, he has double X. So if one X is abnormal and the other one is normal, the other one will be able to produce factor 8, and she will not come down with the disorder as against the male offspring. So she may just be a carrier hemophilia, can only transfer those to her sons. All right, so this is a diagram trying to summarize the inheritance patterns for hemophilia. You can see the unaffected father, unaffected carrier mother. You see, one of her X chromosomes has he has one affected S chromosome. So it's not all the time that she will donate that S chromosome to the son. So it depends on how the inheritance happen, but there is 25% chance that she will have a hemophilia boy, okay, and then a carrier female, right? So some of the laboratory findings we'll see in hemophilia is that APTT is increased. You should be able to explain why that should happen. Okay, as a clue, APTT, we use APTT to monitor the intrinsic coagulation pathway, and factor 8 that we are talking about is on the intrinsic coagulation pathway. So APTT will be prolonged because of the absence of factor 8. Normal PT, factor 8 is reduced, normal platelet count and bleeding time, okay? Those ones are not affected. So treatments include, there's been a lot of advancement in treatment of hemophilia. Initially, they initially used cryoprecipitates because of transmission of infected disorder, HIV, hepatitis. That's use has reduced. So use of concentrated factor products have drastically reduced. The advanced improvement on that is the recombinant factor product developed in a lab through DNA technology. Okay, but there have been other advances like gene therapy and then stem cell stem cell implants or stuff like that. So coagulation factor inhibitor. We need to discuss this, just throw a light on it, because sometimes hemophilia patients receiving factor 8, they're on a lifetime factor 8 prophylaxis or treatment, depending. So because of that, sometimes they develop inhibitor, okay, because the long-term use of factor 8, sometimes their body develop inhibitors against those factor 8, and when that happens, giving them factor 8 will no longer work, because they have developed antibodies that tend to counter the factor 8 that are being given. So sometimes we screen them for inhibitors to know exactly how they will be treated or monitored. So factor 8 inhibitor are acquired antibodies against coagulation factor, resulting in impaired factor function. Anti-factor 8 is the most common antibody blocking factor 8. It is similar to factor 8. Okay, it is similar to factor 8, but we can distinguish it in the lab by performing what we call mixing studies. We will see that when we go to our laboratory investigation. So another disorder of secondary hemostasis is what we call von Willebrand disease. We are just going to describe these disorders. We're not going to so much into details of each. So von Willebrand disease is a genetic deficiency of what we call von Willebrand factor. We say that it is the most common inherited coagulation disorder. It has subtypes, okay? It causes can be quantitative or it can be qualitative. The most common type is autosomal dominant with decreased factor, von Willebrand factor level. The clinical presentation of von Willebrand factor include commonly present with mild mucosal and skin bleeding. And then the laboratory finding include, here we have low von Willebrand factor, where in the process of primary hemostasis, we say that immediately the subendothelial cells are being exposed. That is when the endothelium are injured and the subendothelium are exposed. The collagens and the von Willebrand factor, they are being exposed. And even the von Willebrand factor in the alpha granules or platelets are also being released. So when these von Willebrand factors are being exposed, and we also say that von Willebrand factor is an adhesive protein, okay? So since von Willebrand factor in von Willebrand disease, we say that it is as a result of deficiency of von Willebrand factor, it's low. All these functions have listed that von Willebrand factor is involved in during the process of primary hemostasis will also be impaired. That is what this statement means. Since low von Willebrand factor impairs platelet function, platelet adhesion. Okay, so we will find in the laboratory increased bleeding time because the platelets are not adhering and they are not aggregating. There's no way clotting can initiates in the first place. So we also have increased APTT and normal PT. APTT is involved because von Willebrand factor also served as a carrier molecule for factor 8. Okay, so when it is not there, factor 8 is being destroyed from circulation faster. So factor 8 may temporarily not be there to participate in secondary hemostasis. That is why APTT is being affected in von Willebrand disease, because of its ability to bind with factor 8 and stabilize factor 8 in the coagulation, in the circulation. Abnormal resuscitating test, that is the laboratory investigation we use to monitor the function, platelet aggregation. Of course, it will be abnormal because the platelet adhesion process and aggregation process are also impaired. So treatment, to treat von Willebrand factor, basically depending on the type, which we are not going into too much details because it's beyond your scope for now, Treatments, less treatment, we can use desmopressin. What it does is to release von Willebrand factor from the Weber palate bodies of the endothelial cells. Okay, so it causes a release of stored von Willebrand factor from the endothelial cells to participate in the process of hemostasis. So we also have a vitamin K deficiency. Okay, vitamin K is necessary for the gamma carboxylation of vitamins 2, 7, 9, 10, and protein C and S. Okay, so deficiency of vitamin K, it can occur in newborn because their intestine is still sterile, it's not yet colonized by bacteria, or deficiency of vitamin K can also result as a result of long-term antibiotic therapy. Antibiotic therapy long-term kills the normal flora of the GIT, or can also occur as a result of malabsorption, fat-soluble vitamin. Okay, also in liver failure, okay, when someone has a liver disease or liver failure, to drastically affect coagulation system, because there will be a decreased production of coagulation factors and decreased activation of vitamin K by the epoxide reductase. Okay, so that is the few we can take on primary hemostatic disorders and secondary hemostatic disorders. And also briefly, we are going to look at one or two laboratory investigations we use in hemostasis and thrombosis, right? So laboratory investigations of bleeding disorders, we have bleeding time. One, we have bleeding time. It is used for predicting the risk of bleeding in relation to surgery, okay? To predict whether someone that is booked for surgery may bleed unnecessarily, because the bleeding time, we use it to monitor the integrity of the blood vessel. Okay, so but this test is very difficult to standardize, and there is a lot of wide inter and intra user variability. Okay, so I think it's been replaced with closure time. Yes, closure time. We no longer carry it out now. Platelet closure time, PCT. Yeah. Then to do bleeding time in those days, they use the IV method or the earlobe, called the Duke's method. So in the IV method, a pressure cuff on the upper arm and inflates to 40 millimeters of mercury. So you apply the sphic to the upper arm and inflates the pressure to 40 millimeters of mercury. Use disposable lancet to take two separate cuts into the forearm apart in quick succession and start a stopwatch. Use filter paper. Use filter paper to draw off the blood every 30 seconds. The time when the incision is made until bleeding stops is called the bleeding time. Okay, so the Duke's method put the pressure on the upper arm. Okay, as you can find in this diagram, you can see it in this diagram. This is the pressure curve inflated to 40 millimeters of mercury, then using the lancet to add the incisions and using the filter paper to remove the blood as it forms, and then timing it to the time the using of the blood will stop. So this method has some advantages and disadvantages. The advantages is that it is the only diagnostic test assessing platelet function in vivo. Okay, so it's assessing the function of the platelets inside the body, unlike the ones we do platelets function evaluation in the test tube. So this one is actually doing it as it's happening inside the body. It is simple though, it is fast, it is a bedside test, does not imply sample manipulation. Okay, It assesses platelet function in the presence of all the cellular components involved. Okay. It assesses platelet function under flow condition. That is condition through which the blood is still flowing under the blood vessels and is evaluating platelet function. That's a very good advantage. But its disadvantage is that it's had low reproducibility. Okay, very low reproducibility, wide variation of the normal range, very wide variation, requires skilled technician. It is strongly influenced by many variables. Many variables can affect their result. The skin thickness, for example, the skin thickness, room temperature, venous pressure, position, orientation of the skin wound, patient cooperation. So all these things affect the results. It is invasive, very invasive, and may leave scars on the patient. Bleeding time is altered in thrombocytopenia. So if you get an abnormal results can be as a result of thrombocytopenia, von Willebrand disease, inherited platelet function disorders, acquired platelet function disorders, and some blood clotting or connective tissue disorders, drugs. So in these situations, the results of bleeding time may be altered. So we have the prothrombin time described by Quick in 1935 to measure prothrombin time, factor 2. It is sensitive to abnormalities of the intrinsic pathway and the common pathway. It measures the activity, yeah. It is a one-stage or a two-stage based upon the time required for a fibrin clot to form after addition of tissue factor, phospholipid, calcium, and all that. So the principle of the test is that it measures the activities of the extrinsic and common pathway of coagulation, and therefore dependent on the functional activities of all the factors that are involved in the extrinsic and the common pathway. Factors 7, 10, 5, 2, and fibrinogen. So the method basically depends on the manufacturer's instructions. So the kits these days are available. So as you buy the kit, you must follow the manufacturer's instruction. Basically, it is the addition of platelet poor plasma. Okay. Collect the samples in trisodium citrate. Okay. 9:1, the ratio of 9:1. So you prepare a platelet poor plasma. So the anticoagulant of choice when we are carrying out coagulation study is trisodium citrate. Okay, the trisodium citrate is the anticoagulation of choice. Okay, so after adding your blood to the trisodium citrate in the ratio of 9:1, you prepare your platelet poor plasma. Okay, so you spin the blood samples at the very for you to generate a platelet poor plasma that the platelet count is very low. So you spin it in such a way that you get platelet poor plasma. Then calcium is added to initiate coagulation. A stopwatch is added, is started. Okay, and the time for clots to form, it's recorded. Reference range, Caucasian reference range is 13 to 15 seconds. Right. Okay. So the prothrombin time reference range depends upon a number of variables. So there are some variables that affect the reference range of prothrombin time. For example, the source of tissue factor. Is it from human or from rabbit? So when you open your kit insert, you'll be able to read very well to know where the source of the tissue factor, whether it's human or rabbit. The exact technique used will also affect the results. Did you use manual method? Did you use semi-auto? Did you use fully automated method? Okay. Method of endpoint determination. Okay, the instrument you are using, how does it determine the time of clot? Is it optical Is it optical or is it mechanical? Okay. The PT forms the basis for monitoring oral vitamin K antagonists like warfarin. Patients on warfarin, they determine their INR ratio, okay, using the ISI index. The PT value, okay, so individual, okay, all right, okay. So we also have the activated partial thromboplastin time, initially called the kaolin cephalin clotting time, or the partial thromboplastin time with kaolin. These are initial names that you were given, but now it's activated partial thromboplastin time. The principle of the text is that it measures the activity of the intrinsic and common pathway of coagulation. So therefore, it depends on the functional activities of factors 12, 11, 8, 10, 5, 2, and fibrinogen. That's factors of the intrinsic pathway and the common pathway. Okay. The method, once again, collect your blood samples, generate the platelet plasma, and use following the manufacturer's instruction to perform the test. Okay. All right. Thank you. So we'll end it here. There are any questions, we will take that during our physical class. So for now, it's bye. Bye. Okay. Right.